Welcome guys to the GEP Crash Course series. So you've got myself, Ash, and got Emily here, and we'll be going through some SBAs for your second set of exams. Just in the top corner, we've got our Instagram QR code if you guys want to follow, and down in the bottom corner, we've got our email address if anyone wants to, if anyone has any questions, and just email us. And we are also trying to recruit, so if you're interested in doing some teaching, please do email us as well. So we'll be going through about 24 practice SBAs, covering things like O&G, Paeds, elderly care, neurology, psychiatry, MSK, Derm, and Rheum as well. Is there anything else you want to add, Emily? Nope. So here's your first question. So you got a 27-year-old woman and her partner come to see you in clinic 7 days after giving birth to a healthy baby girl. Her partner describes her having severe mood swings over the past few days and being extremely irritable. What? She appears restless, and on questioning her mood, she says she would feel better if her neighbour stopped saying such horrible things. What is the appropriate management? So I'll open the polls and I'll give you about 20 to 30 seconds to answer.
Do we take pictures of it? I think we should. I hope so.
I'll give you about 10 more seconds. Okay, I'm going to stop the polls now. So you can see the answers are quite split here between A, B, C, and E. So the correct answer is actually E. So referring urgent need for a psychiatric assessment. So this patient's showing signs suggestive of probable puerperal psychosis. So she's hearing voices, she's quite irritable, she's having these mood swings, and it's within the first 2 weeks. It's very rare, but it does need an urgent assessment. So low mood is common after childbirth. So this is known as your baby blues, and it usually resolves within like the first 3 to 4 days. And then postnatal depression is more likely to present from 4 weeks after the birth itself. And the rest of the things here after the assessment might be considered, but the initial thing to do is get an urgent assessment done. Okay, so next question. So question 2, a 32-year-old woman presents to the labour ward with painful contractions. On cervical examination, the cervix is 6 centimetres dilated. What stage of labour is this woman in? So opening up the polls. Okay, give you about 5 more seconds. Okay, I'm going to close the polls now. So I think most people have put down D, which and then I got a split between A and B as well. So the actual answer is B, so stage 1, and it's in the active phase. So each stage has the first 2 stages have an active and a latent phase. So this woman is having painful contractions, but her cervix isn't fully dilated. Therefore, she is in stage 1 of labour. As she's dilated between like more than 4 centimeters, she's in the active phase. If it was less than 4 centimeters, then it would be the latent phase. The second stage is when she's fully dilated, and then whether she's actively trying to expel the baby or not will determine if she's in the latent phase or the active phase. And then your stage 3 is when you get rid of the placenta. Oh. Next question. So question 3. Which statement about oral combined HRT is not true? So I'll open up the poll. I'll give you about 10 more seconds. Okay, I'm going to close the polls now. So most people put down C. I've got a few E's there. No, the answer is C. So HRT actually improves your glycemic control. So C is not true. So it actually decreases your risk of getting type 2 diabetes. With combined HRT, you've got the estrogen prep in there. So this also increases your risk of getting VTE, and thus also increases your risk of getting a stroke. It's also very small percentage, but it does increase the risk of getting breast cancer as well. So within an SBA, you would say that's true. The other thing that you should know is that estrogen itself is actually cardioprotective, so you're less likely to get any kind of cardiac issues. It also protects your bones. So once you reach menopause, your bones become more fragile, so you're more prone to getting fragility fractures. With estrogen, it kind of prevents the decline of the bone density itself. And then you've got your progesterone components in there as well, just as an add-on bit of information, which protects the lining of the endometrial lining, so that reduces the risk of your endometrial cancers. Okay, so next SBA. So you got a genetically female newborn is found to have ambiguous genitalia with virilization features and a bronze skin color. Deficiency in which enzyme is most likely to lead to this presentation? So we're going to open the polls. I'll give you about 10 more seconds. I can see people just changing their answers here. Okay, I'm going to close the polls now. So most people have put down D, which is the correct answer. So it is a 21 alpha hydroxylase deficiency, which leads to this sort of presentation. So your 21 alpha hydroxylase is a deficiency also known as congenital adrenal hyperplasia. So in anyone that is genetically female, they'll end up with high levels of androgen exposure, which leads to virilization of their genitalia. And this is where you end up with this ambiguous genitalia and being assigned the wrong gender at birth. The other thing that you need to be aware is that it can also lead to salt wasting due to the lack of aldosterone being produced, and this is usually corrected with your glucocorticoids. And one more thing is that your blood pressure can also be low, and just due to the effect on the RAS system without the aldosterone there. In less severe cases, you can have early puberty, excess growth, and decreased fertility. Another key point here to just remember for exams is that it's autosomal recessive. Just going through some of the other options here, you got your 17 alpha hydroxylase deficiency, which is another rare form of your congenital adrenal hyperplasia, which results in just a glucocorticoid deficiency. And you can get this hypogonadotrophic hypogonadism, and you can get severe hypokalemic hypertension. So in males, it can also lead to undervirilization and lack of pubertal development as well in both genders. And again, this is also autosomal recessive. Then you've got your 5-alpha reductase, and this in genetically male patients, they'll end up with the lack of DHT, so they won't develop their external features and kind of appear female. And depending on the level of enzyme block, their ambiguity can kind of vary. Depending on the level of block and at the stage of puberty, depend on how high the testosterone levels are, it can actually induce virilization. So it will make it a bit more clear if they're female or male. And then you've got your 3-beta dehydrogenase. In genetically male patients, it will have varying abnormalities. So key kind of features you'll see is like the opening of the urethra will be under the penis, and you'll also end up just on going along the spectrum, just having ambiguous genitalia. In females, so genetically female patients, they may have premature hair growth or hirsutism, irregular menstruation, and just fertility issues as well. And some of the subtypes you might want to remember is just any salt wasting, or they can be non-salt wasting. So in those who are salt wasting, the hormone produced is just very, very low. But non-salt wasting is the more classical and not the mildest form that you can have. And then your last option, E, 17 hydroxyprogesterone. This is actually used to diagnose and monitor your congenital adrenal hyperplasia. It's not an actual enzyme, it's the hormone itself which is being monitored. Oh. And so going on to the next question. This graph illustrates changes in hormones throughout the menstrual cycle. Which hormone is represented by the green dotted line? So opening up the polls, just give you a bit of time to have a look at the diagram. So I'll just point out which line we're talking about, this green line here. Just give it about 10 more seconds. Okay, I'm going to close the polls now. So everyone put C, so well done. So Your green line is your LH. So this triggers your ovulation and the development of the corpus luteum itself. Your blue line is your estrogen, which helps develop the lining of the uterus. The red line is your FSH, which stimulates the follicle to mature. And then this orange dotted line here that you see is your progesterone, which maintains the lining after ovulation. I think it's Emily next.
Hi, sorry, my mouse got lost. So a mother brings her 2-year-old daughter, Leela, into the GP with concerns about her development. She'd been lagging behind the speed at which her older siblings developed. On inspection, Leela is cooing and playing with her toes. Taking a closer look, the GP notices low set ears, epicanthal folds and a sandal gap. She has small grey spots on the iris. What's the most likely diagnosis? I'll give you sort of 10 more seconds. Okay. So the correct answer is E, Down syndrome. So the things to sort of pay attention to, so cooing at 2 years tells you that this is developmental delay, because by 2 you should sort of be able to put words together, and by 1 you should be saying single words. I've just on the next slide, I've just got some different. So sorry. So the sorry, sorry. So these are just what those things are. So epicanthal folds, you can see in the picture at the bottom, and then often in Down syndrome they get these low set ears, a sandal gap between the toes. Again, that's the picture of the foot, and these sort of grey white spots on the iris, which we call brush field spots. And this is sort of typical appearance in Down syndrome. In the next slide, I've just put some other conditions together. So on the left, we've got those are the deletions or loss of function syndromes. So most question, to be honest, that you'll probably get would be Down syndrome, but these ones will occasionally prop up. Yeah, so DeGeorge's deletion in the middle of chromosome 22. And again, developmental delay, congenital heart problems, speech and hearing problems. You get sometimes you get this cleft lip or palate, low set ears, flattened philtrum, and wide set eyes. Angelman, which is just below developmental delay again, wide mouth, widely spaced teeth. Prader-Willi, absence of genes on chromosome 15. And you could get hypotonia, early onset obesity, behavioural problems, hypogonadism. And then on the right, there's trisomy 13, which is Patel, and trisomy 18, which is Edwards syndrome. You don't need to know every single detail of these, but I'd be able to kind of recognise some of the key features in exam questions. But most of the time it probably would be Down syndrome, but just to kind of be aware of the others. If you have any questions, by the way, just pop them on the chat. We can have a look. But yeah, next question. 59-year-old lady came to to the GP. She has aches all over and knee pain on the right. A Waddling Gate was noticed, and she had decreased power in the legs. She was diagnosed with osteoarthritis of the knee 10 years ago and has been less mobile since then, and now rarely leaves the house. Prior to this appointment, she was sent for a DEXA scan. Her T-score was minus 0.7. What is the most likely diagnosis? I'll give you 10 more seconds. Oh, lots of changing answers in this one. Okay, I'll stop it there. So I think most people said B, or some people said C. The answer here is actually C. So the things that kind of point you towards osteomalacia are the Waddling Gait. There aren't symptoms of any hypercalcemia, and you've got risk factors for vitamin D deficiency. So it's not osteopenia, because if you go to the next slide, osteopenia is T-score of -1 to -2.5, and is generally asymptomatic. So osteoporosis is the T-score less than or equal to -2.5, and then osteopenia is -1 to -2.5. So I think in the question it was -0.7, so it's not quite bad enough even for osteopenia. Osteopenia is also asymptomatic most of the time, unless you have fractures, but that generally then suggests it's probably osteoporosis. So again, they're generally asymptomatic until you actually have a fracture. Osteomalacia is the painful one. So you get bone pain, tenderness, fractures. You get this Waddling Gait due to the proximal myopathy. And I've just sort of put, key risk factors, causes. Osteomalacia is normally due to vitamin D deficiency. And remember, rickets is basically the same thing, but in a child. Hyperparathyroidism is where you get inappropriate secretion of PTH. It'd be a very mean question if it's trying to get you to distinguish. This is a mean question, but hyperparathyroidism and osteomalacia in blood tests could come up trying to distinguish them. So osteomalacia, you'd get a normal or a slightly low calcium and a high PTH. In hyperparathyroidism, you'll have a high calcium on the routine tests. So to kind of summarize the differences of osteomalacia and hyperparathyroidism, both can cause high PTH, but in osteomalacia you get low calcium and normal positive feedback because the body's trying to increase the calcium. In hyperparathyroidism, PTH release is inappropriate, so you have a high calcium and therefore you get symptoms of high calcium. Okay, next question. Which of the following is not a risk factor for osteoporosis? Okay, I'll stop the poll. So most people have said E, which is the correct answer. So hormone replacement therapy. So hormone therapy means more estrogen, and estrogen is protective. You can use, this is the sort of acronym that I use to remember the risk factors of osteoporosis. So steroid use, hyperthyroidism, hyperparathyroidism, alcohol, tobacco, being thin, low testosterone, early menopause, renal or liver disease, erosive inflammatory bone disease, and dietary such as low calcium and malabsorption. I've just added them to the table as well, so you guys have this. Yeah, I won't go through all of it now, but I like tables just to, especially when things are quite similar. I used to get really confused between all of these things, so it's helpful to kind of have it all in one place. So I'll let you go through that later. So I'll pass back to Ash.
Cool. So we've got our next question here. So this image illustrates a left homonymous superior quadrantanopia. Where is the lesion? So I'll open up the polls. Give it about 10 more seconds. Okay. You see people changing their answers around now. I'll give you about 5 more seconds, just so people can confirm their answers. Okay, let's stop the polls now. So most people put down B, which is the correct answer. So I'm just going to go through this sort of systematically, and then it'll kind of make sense why that's the answer. So just starting from the top, where you have the optic nerve coming here. So if you have a lesion there, you'll lose your vision in that eye. So that's your monocular loss, so your one eye loss. Going further down, you've got your optic chiasm here. So any lesion there, you'll end up with your bitemporal hemianopia. So just loss of the visual fields on the outside, your temporal visual fields. And then going further down, you've got your optic tracts here. So remember, things are crossing over at the chiasm, and you've got things coming from the same side as well. So this leads to a homonymous hemianopia. So it's a specific visual field. So in this case, you've got a left field. So we'll just follow on the left side. So anything that's on the left side will reflect onto the right side of the eye here. Okay, so you can see these dotted lines. That's the direction where the light's coming and touching the retina. So your left field will be reflected onto the right tracks that are going into the brain. So following through there. So if you have a lesion here in the optic tract, you'll have a left homonymous hemianopia. So it'll be the whole half which is shaded in like this. Then you get to these bioptic radiations here. So your bounds loops and your Myers loops, which is underneath. So your bounds loop is your superior, which goes to the lower right calcarine fissure. So this is where you get your superior quadrantanopia. If it was your Myers loops which got the lesion in it, that's going to the upper calcaneal fissure, which means you'll get an inferior quadrantanopia instead. So moving on to the next question. So a destructive lesion of the entire right side of the spinal cord at T12 location is most likely to produce what sign in a patient? I'll open up the polls. Give you about 10 more seconds. Okay, I'm going to stop the polls there. So you can see most people put down A, which is the correct answer. So this question itself is describing Brown-Séquard syndrome. So we have a lesion which is just causing a lesion in just half of the spinal cord. So in Brown-Séquard syndrome, you get this ipsilateral loss of your motor, proprioception, and your vibration sensation, and contralateral loss of pain and temperature. And this is mainly due to where the tracts themselves decussate. So the corticospinal tract and the dorsal columns both decussate at the level of the medulla. So the corticospinal tract, remember, is your motor, and then your dorsal column is your proprioception and your vibration sensation. Then your pain and your temperature is passed through the spinothalamic tract, which actually decussates at the level of the spine, and it's one level above where the lesion, one level above where it originates. So in this case, it will be L1 and below where they'll have the deficit, as it's decussating up at T12, and that's where the lesion is. And then I put this diagram in here just because I thought it was quite useful, just to kind of illustrate what's going on. So you can see here, this is where the lesion is. You'll have a loss of sensation on this side, and then on this side it's just one level below where you have the loss of pain and temperature on this side. Okay, next question. You have a 23-year-old female who presents with unilateral pulsating headache lasting 5 hours. She complains that a headache was produced by bright and flashing lights and is associated with photophobia, noise sensitivity. She also had 2 episodes of vomiting and still feels nauseous. What is the acute treatment of this type of headache? So I'll open up the polls. Give it about 10 more seconds. Okay, I'm going to close the polls now. So most people put down B, which is the correct answer. So For acute management, you'd want to give an NSAID and a triptan. So in this case, the triptan is your sumatriptan, and your NSAID of choice here is your ibuprofen. For prophylaxis of migraine, then you can give your topiramate or your propranolol. Paracetamol and caffeine won't really help with migraines, and sublingual GTN spray not given here either. The other thing to remember here is in young people, for example, anyone who's kind of aged 12 to 17, you might want to consider giving them nasal triptans. Okay, and then I'm not going to go through this, but I've just put in a table which I stole from our own lecture series, which I thought was quite useful, just going through the different headaches, the features, triggers, and the management as well. Cool. Next question. So, accommodation of the eye is regulated by the autonomic nervous system. Which muscle is innervated by the ANS for accommodation reflex? So, opening up the pulse. Okay, I think most people have answered, but I'll give you about 10 more seconds. Okay, I'm going to stop the polls now. Bit of a split here. So the correct answer is actually A, so the ciliary muscles. So your ciliary muscle helps kind of broaden the lens, and this also helps with your dilation. And then your constrictor pupillae constricts the iris to constrict your pupils. So these are the two muscles which are used, and obviously the only option here was the ciliary. Your inferior oblique helps pull the eye up and out. Your superior oblique is the one that helps your eye move down and out. Your middle muscles is the muscle that helps open up your upper eyelid. And then your orbicularis oculi helps with closing your eyelids. Okay, question 13. So we've got an 80-year-old female who was brought into clinic by her daughter who reports persistent and progressive decline in cognitive functioning, including memory loss and impaired function at home, and followed by an inability to recognize friends without prompting and mild behavior changes. She's still able to get around, but her daughter doesn't feel it is safe. Which is the best management for this condition? Oh, sorry. Hopefully no one saw that. Okay, give it about 10 more seconds. Okay, I'm going to close the polls now. I think most people actually saw the answer there, but so A is the correct answer. So donepezil is your acetylcholine esterase inhibitors, and they're usually the first line for mild to moderate dementia. So this is kind of this impaired memory, impaired kind of executive functioning, and just having difficulties with just daily living. Memantine is usually given for any sort of moderate to severe. Antidepressants and antipsychotics, such as fluoxetine, can be given for things like frontotemporal dementia. Your Ciliary is your monoamine oxidase inhibitor, and it's used mostly in Parkinson's. And you got your clomipiromide, which is a tricyclic antidepressant. I think it's Emily next. Yep.
Yes, so a 55-year-old male presents to the clinic with a pin rolling tremor and muscle rigidity, suggesting a case of Parkinson's disease. What gait is usually seen in this condition? Ten more seconds. Okay. Yes, so everyone said B. Very good. So yes, typical shuffling gait in Parkinson's disease. And one way of remembering the different symptoms is the TRAP. So tremor, which is the resting tremor, rigidity, akinesia, and postural instability. So yeah, shuffling gait, you get this really stiff. You slide your feet along the floor. The other kind of types of gait, so you can get the waddling gait, which is a myopathic gait, which is due to the weakness of the hip abductors, which means that you kind of swing your leg round rather than swinging it forward. You get hemiplegic gait, which is caused by lesion in the central nervous system, such as a stroke, which causes the unilateral weakness, and you get spasticity. Neuropathic gait, which is where you get the high steppage gait due to the weakness of the distal limb. And those are the sort of main types of gait. And just basically just need to know the symptoms of Parkinson's disease fairly well. This was quite an easy question, but you'll get some like this, and then you'll get some harder ones as well. And the other thing with Parkinson's is the micrographia, and the writing just gets smaller. So you could get a question with sort of one of these symptoms, which is supposed to point you towards Parkinson's disease. Okay, next question. A 50-year-old male presents to ED with right-sided weakness of the upper and lower limb with power 3 out of 5. On further examination, right-sided facial palsy was observed. Which region of the brain is most likely to be affected? Okay, I'll give you another 10 seconds. And I'll stop it there. So most people said B, and there's one D as well. So the answer is B. So the weakness tells you that the problem is in the motor cortex, which is in the parietal lobe of the cerebrum. And then you need to remember that the fibers crossing the spinal cord, as Ash was saying. So the problem in the cortex will be on the contralateral side of the lesion. So these signs indicate a total anterior circulation stroke, which is the MCA and the ACA. It's not a cerebellar stroke, because you get these sort of Danish symptoms, and the symptoms would also be on the same side. I've just said Danish now, I can't actually remember what they'll stand for.
Look it up later and just put it in the chat.
Yeah.
I'll put it in the chat now.
Yeah, no, so the Danish, so yeah, dysdiadochokinesia, ataxia, nystagmus, intention tremor, you get scanning dysarthria and heel shin test positivity. So it's a good way of remembering the cerebellum and symptoms of a cerebellar dysfunction. Okay, next question. So a 65-year-old female presented 6 hours ago to ED with aphasia and right-sided weakness. She was diagnosed with a transient ischemic attack and is now fully recovered. Which of the following investigations is the most important to be carried out for this patient as a follow-up? Oh, sorry, I need to do that. 1 second. Okay, I'll give it 10 seconds. The answers are changing. Okay, and I'll stop it there. So we've got a bit of mix of answers here. So we've got some D's, A's, B's. The answer is D. So if when the patient first arrives, you need to do a CT head. If it's a low risk TIA, you might just come straight to the TIA clinic where they do a CT. But the important thing to do is a carotid Doppler. In this question, she's already recovered, so this is within 24 hours. So we're not focusing on making her better. We're focusing on trying to prevent future stroke. So a carotid Doppler would show you, obviously, if there's a blockage in the carotid artery, and if the blockage is still there, then that's going to sort of break up, and you could cause further clots. A is also a reasonable answer. MRI head might be done in complicated cases, but it's not the standard practice in strokes. The most important one here is the carotid Doppler. And if the patient's fit for surgery, then the vascular team will get involved, and if there's a significant narrowing, then they can remove it, and that's called an endarterectomy. This is surgery. We don't do EEGs for stroke. Generally, that's more sort of epilepsy and things like that. You might do an EEG if you're not sure if it was a seizure. The other important test is an ECG that we always do in a TIA clinic, and that's to look for AF, which is another important risk factor for strokes, as you can get a cardiogenic embolism. So TIA clinic, generally you do ECG, do a little bit of a history workup. They'll have a CT if they haven't had one already, and they'll have a carotid Doppler, and then if the consultant thinks it's appropriate or they're not sure what's going on, I think something could be a brain tumor or something like that, then they might do an MRI. but yeah, not as a standard practice. Okay, next question. So a 65-year-old female presents with stiffness and pain in her hip joint, worsens with exertion. She's also got pain and a lump on her dip of her first finger. Which of the following signs is most likely to be present on examination of her hands? Okay, it could be 10 seconds. Okay, I'll stop it there. So everyone has got the correct answer. Well done. You clearly knows this very well. So the answer is E, which is Heberden's nodes. So Heberden's nodes, as you clearly do know, are present. You get them on this sort of the dip joints. They're associated with osteoarthritis. On the next slide, I've just got some pictures of the different deformities. So in osteoarthritis, you can get Heberden's nodes and Bouchard's nodes as well. Heberden's nodes are present in the dip joints, which is obviously the distal. The way that I was taught this at St George's, you maybe still be taught this, was the outer Hebrides, kind of thinking they're a long way away, so they're the furthest ones away. And then the Bouchard's nodes you get on the proximal, the pips. The other joint deformities are more likely to be present in rheumatoid arthritis, and there's just a picture here. So you can get this subluxation, swan neck deformities, and boutonnieres. Yeah. Okay. Next question. Which feature can typically be found on the X-ray of a patient with advanced osteoarthritis? Okay, it could be 10 seconds. Okay, I'll stop it there. So most people have said A or done, and E as well. So the answer is A, so subchondral sclerosis. So in osteoarthritis, you can use a loss mnemonic, which I realise here isn't that helpful to distinguish between subchondral sclerosis or subluxation. But the typical features in osteoarthritis are this subchondral sclerosis, which you can see in this picture. You kind of get this sort of hardening of the bone, which is kind of a whiteness. So you get the loss of joint space, osteophytes, which are these kind of almost bites out of the bone, subchondral cysts, which are kind of like bites but not on the outside, and subchondral sclerosis, which is this sort of hardening. They love this question. This question comes up absolutely everywhere, in all years of medicine. So a good one to make sure you commit to memory. Okay, next question. What type of fracture is this? Okay, 10 seconds. Getting towards the end now, only a few more left. Okay, and I'll stop it there. So we've got a few different answers here. We've got E's, A's, and C's. So the answer here is E. So a comminuted fracture is where you get lots of fragments. You get these kind of it breaks in lots of different places. So well, the other option. So transverse here, you get a transverse fracture is kind of just a cut across the bone, which is quite a sort of typical fracture. You can get the other people said C, so oblique non-displaced. So again, so oblique is where you get this, this diagonal cut. Displaced is when it's moved, so there's a gap between the bones. And then the other one here is a green stick fracture, which is a bit like it's pediatric fracture. It's a bit like when you break a stick and it kind of the bark doesn't quite break, and it's kind of, or the bark slightly breaks, but the rest of it doesn't. It's a bit of a weird children's fracture. You don't get that in adults, but yeah, the comminuted, which basically means multiple fragments.
I think one of the questions was if a commutative is similar to a compression. I think they're not interchangeable, are they? Though.
No. So, oh, sorry, I've missed that. Yes. So I think they can be hard to distinguish between the two fractures, but compression fracture. That's actually a really good question. I don't know how to describe it. You could have a compression fracture that's also, sorry?
I think it's more to do with the mechanism as well.
Yeah.
And the level of displacement that you get with it.
Yeah.
Yeah. But it's definitely not interchangeable.
No, not interchangeable. But you could potentially have a compression fracture that is also comminuted.
Yeah.
But yeah, to do with the mechanism, and also compression fractures you often talk about as like vertebral fractures and stuff, where you get wedge fractures where part of it kind of squashes. So here it's not squashed, it's kind of it's still the same size, it's not lengthened or shortened the bone. So often compression, you talk about bone shortening as well. So it's kind of, yeah, it could be both, but yeah, there is a slightly different meaning to the different terms.
Cool. So I think I'm next, aren't I?
Yes.
Cool. Okay, so next question. So vitamin D homeostasis occurs in the GI tract, kidneys, bones, and parathyroid glands. Which form of vitamin D is the active form? So opening up the polls. I think my cough's slowly coming back now.
Okay,
give about 10 more seconds. Okay, I'm going to stop the polls there. So, see, most people put down E, which is the correct answer. So it's your calcitriol, which is your active form. So your cholecalciferol and your calcidiol, basically the same thing. And I've just put this image in here so you guys can see like the whole process of it as well, just for your own revision. Okay, so next question. So claw hand is a condition involving extension at the metacarpal phalangeal joint and flexion at the interphalangeal joint of both the fourth and fifth fingers. Which nerve is involved in this deformity? So I'll open up the poll. Okay, give it about 10 more seconds. Okay, I'm going to close the poll now. So most people have put down A. Got some E's here as well. So the correct answer is A. So with an ulnar nerve any ulnar nerve damage, you'll have extension of your MCP joint, and then you'll have flexion of the interphalangeal joint, which is why you get that claw deformity, and you can't really straighten that out. This differs from your median nerve, where you actually can't flex your second or third fingers, and you've also got loss of opposition of your thumb as well, which is where you get that ape hand. I know the images look very similar. It's just the fact that with your median you can't bend this, but you can bend your fourth and fifth, and then with your ulnar here you can't straighten your fourth and fifth, but you can straighten the second and third. This generally is a good diagram. I just think these having the same image for both of this is not very helpful. The other key one to remember is your radial nerve damage, which is your wrist drop. Axillary, you get this flaccid deltoid and loss of abduction of the shoulders, and your musculoskeletal, you'll have loss of feeling in your lateral part of the forearm as well. Cool. Next question. You have a 20-year-old female who presents with a 6-month history of morning stiffness in the PIP and MCP joints that is relieved by movement. She is diagnosed with rheumatoid arthritis. Which of the following features is not seen on X-ray in this condition? I'll open up the poll. Okay, give about 10 more seconds. Okay, I'm going to close the polls now. So everyone's put down B, which is the correct answer. So osteophytes are only found in OA and not in RA. Joint space narrowing can be found in both, but the rest of the features are more in line with RA than OA. So I put this table in here because it's quite useful. I'm just going through the different clinical features of OA versus your RA. And then you can see here, so Emily's already gone through a bit of this as well for OA, but I just thought I'll go through the RA ones. Just comparing it to the normal hand, you can see the loss of joint space there. You can see subluxation of the joint and the thumb. You can see this kind of ulnar deviation where your hand's kind of going towards the ulnar side. You can see these erosions in the bone to there. And the other feature here is your kind of soft tissue swelling. So if you compare it to this X-ray of a normal hand, you can see there's a lot more soft tissue around the fingers than there is in these fingers. Cool. So next one, I think Emily.
Yes. So I think there were 2 more questions. Well done staying this far. Number 23, a 50-year-old lady with rheumatoid arthritis tends to GP with flu-like symptoms and strange bruising. Her recent COVID-19 PCR test is negative. She's on no medication other than methotrexate. The GP notes a temperature of 38.5, heart rate of 100 20, BP 100/70, and she looks quite pale. What should the GP do next? Is the poll working? It said.
Do you want me to press it?
I picked it and it said another poll is already open. It was going to
close
it, but it doesn't seem to be working. Yeah, if you don't mind doing the poll, please.
Cool, got it open. There you go.
My phone's being weird. Okay, 10 more seconds. And I'm going to stop it. Maybe my phone lets me do that. Is it stopped?
I've stopped it, don't worry.
Okay, cool. So everyone has said E, but the answer is actually D. So in this question, basically what we're hinting at here is neutropenic sepsis. So a rare side effect of methotrexate is blood dyscrasias, which is abnormalities, which include aplastic anemia, which can cause a deficiency in all of the blood cells. This means your immune system won't be working, and then therefore you can develop neutropenic sepsis. This may not be neutropenic sepsis, but she has got symptoms of sepsis. She has got a high heart rate, she's got a high temperature, and her blood pressure is low-ish, probably quite low for a 50-year-old lady. So we need to, ideally, we would take blood test and see what's going on and check that it's not neutropenic sepsis in the GP. Unfortunately, in the GP, that seems that'll take a few days. So if she's clinically unwell, she's also got bruising, which suggests a problem with the platelets. We need to send her to A&E just to get a blood test. If the blood test is normal, then that's absolutely fine. She can go home and rest. But we basically need to rule out neutropenic sepsis in this. So you just need to know that methotrexate, one of the rare side effects of this drug is neutropenic sepsis. Yeah. So next question. So which is the outermost layer of the skin?
I've opened up the polls.
Thanks. My phone seems to think we're on question 20 on the poll.
That's fine. I can read it out to you if you want.
Yeah, if you can just do that. This is the last question.
Just let me know when you want me to stop it.
Yeah, if people have answered, then just stop it.
Yeah, good amount, I think.
Yeah, that's fine.
So most people put down E.
The correct answer. So yeah, the way that you can remember is come, let's get sunburnt. So corneum, lucidum, granulosum, spinosum, and then basale. So another very easy question just to put in an exam. So good to know. But yeah, that is it. And try not to get too sunburnt tomorrow. Heat.
Cool. Thanks, guys, for sticking around. So good luck in the exam. That's the QR code for the feedback form, and then I've also put the link to the feedback form in the chat as well. So when you fill in the feedback form, you'll see at the end there's a link to all the handouts. In the handouts, we put together basically 100 SBAs for you to practice. There'll be a version with answers and without answers. It does include some of the SBAs we've included in today's presentation, but there is basically 100 SBA paper that you can practice in your own time as well. Yeah. But yeah, good luck with your exams.
Good luck. Thanks for coming.